right, welcome everyone to our third COVID-19 Community GP Update Primary Care webinar for 2022. I just wanted to first of all acknowledge and pay respects to the land in which we're meeting here this evening. For me, I'm on Kaurna land, Kaurna country, and pay my respects to elders past, present and emerging, and really to acknowledge and just to really thank for all the care and attention that's been paid to the land that we are on today, across the state, interstate, or wherever you may be joining us this evening. So we've got a large number of presenters tonight, which is fabulous to cover some really great key areas. And we've had a lot of feedback into the GP liaison inbox over the last couple of weeks. And Mel's taken a few days off leave, so we've got a backlog of emails that we're getting through at the moment in SA Health in our emails at the moment. So we're hoping we can cover a lot of those really key questions tonight that you've had, and particularly around where some of those pressure points are going to be for us over the coming weeks. I'm going to step through some of the modelling as well, and then I'm going to hand over to Associate Professor Tom Dodd to talk through around where we're up to currently with pathology testing here in the state, a bit of an update around some of those test numbers that we're seeing, and genomics I know we're all quite interested to know more about. And then I'm also going to hand over then to Dr. Jenny Gould, who's the clinical lead of the GP assessment team, who does a fabulous job leading that large group of GPs who support across the Medi hotels and into the community model of care as well. And then now this is probably the thing that we're most excited about tonight, is covering, wait for it, the oral therapies for COVID-19. I don't know, we've had so many emails come through around the new changes that have come in, particularly around the medications that we've seen rolled out across aged care facilities and into the outros as well over the last 2 weeks. So we're very pleased that we've got Dr. Ranji Nelson here this evening, and also Katie Wallace, who is really leading a lot of this work in the pharmacy space to support the rollout of the oral therapies and how that works in with some of the other treatment options that we're utilising for COVID-19. And we've also got Naomi Burgess, our Chief Pharmacist at SA Health, who will be joining us as well to answer any specific questions. But we really wanted to provide some education update as to where we see some of those therapies heading. What are some of the areas that we need to be mindful of as well, if you are particularly involved in aged care prescribing, and as we may see this well, these medications coming onto the PBS, what does that mean for us here in South Australia, particularly with our COVID-19 response? So that's probably a lot for us to cover. So if you have questions, comments, please post them into the Q&A box, and we'll get to those as we progress. And Dr. Mel Smith will be joining us as well, and she'll cover through some of those questions. We just love being able to help and provide advice out to GPs, community practitioners in the state. All right, so I'm going to move through some of these slides. Probably first of all, just go through some of the pathways update, and I won't spend too much time on this, but I did want to draw attention to two factors that have changed slightly from our last webinar, particularly around that population health response that we're seeing with the increase in cases. Now, we know that around 10% of the population in South Australia have now been infected with COVID-19, and we are seeing reinfection occurring here in the state as well. So it's important that we are providing as much upfront health support as we possibly can for people here. And this comes down to, what are we doing now managing COVID in the state? We quickly, rapidly developed a community response program that really centralised that care within SA Health. We're now stepping back through that and providing advice for individuals who are low or medium risk to contact through if they want some additional health advice through to Health Direct, and that's through the National Coronavirus Hotline, mirroring what we've seen in the other states. And then also as part of that, then linking into usual GPs if someone has a usual general practitioner. So if you have your health details linked with Health Direct, please update them, because that is how people will get in contact you, is Health Direct providing referrals across to general practice if you have a usual GP or if someone has a usual GP. So you can see we have that low risk home pathway and that medium risk supportive pathway. Both of those will see that transition across into Health Direct, with increasing numbers over the next 2 weeks that we'll see referrals go across. So that means instead of someone getting a daily text message asking for their symptoms and asking them to contact into SA Health if they have any concerns, they'll be redirected instead to the National Coronavirus Hotline for advice and support. And as part of that, if there's a need, then someone will be escalated then to their usual GP if they have a usual GP. If they don't, then through to the SA health systems. So that's just a bit of an update where we're heading. The second factor in this is around the changes that we're seeing in the Commonwealth GP respiratory clinics, and a number of you work in respiratory clinics, run respiratory clinics who are online tonight. Now, as part of that transition that we saw from the 1st of January, it was around seeing face-to-face patients who are COVID positive and providing some additional care and support. And we're delighted that 3 out of the 4 GPRCs are currently seeing COVID positive patients here in the state. So that's an opportunity for your patients to refer them in if they do need a face-to-face assessment. They're not giving the IV sotrovimab infusions, so those IV infusions are still with our COVID care centres, north, south, centrally, and then out in the regions in a number of our hospitals out there. But it is an opportunity as well, if you can't see your patient face-to-face, that you could refer them to book an appointment. They need to still book an appointment with one of the GPRCs. So it's been great to see really good uptake, and those sites really keen to see how they can support as part of that community response. The next area I wanted to just emphasise again is around the high-risk hospital pathway. So we are really, and I'll show some graphs as well, that we are trending down in our hospital admissions, which is really, really good to see. But we are still requiring that supported care facility environment. And we do now have 2 regional quarantine sites or alternative accommodation centres, one set up in Port Augusta, which has capacity for around 150 individuals. And then we have a site in Ceduna as well, which is focused predominantly on that western area. And we will see, particularly with some of the opening of communities in those regions, such as Oak Valley, we will probably see some change in cases there. And then, of course, WA is experiencing quite a number of cases as well, despite having a closed border arrangement in place. So we expect that we will see more cases in those particular areas. So we're ready if we need additional capacity with supported care facilities. And the reason that we utilise those sites predominantly is when individuals don't have somewhere suitable to quarantine or isolate it. So far, though, we're seeing that lower severity of disease, which I'll talk through here now. So these are the key numbers, and I always find the key numbers are really quite interesting, just to reflect as to where we're heading in this space. So we know that more than 30% of cases now in South Australia are in children, and note that was an expected shift that we were going to see with the returning of schools going back. And particularly as well, seeing younger age groups who don't have the opportunity to be vaccinated. And we know that overall, approximately 70% of cases are under the age of 40. So we're just not seeing that high severity of illness that we were expecting to see, particularly in the acute space. So around 65% of patients are admitted into the RAR in Carlin, and then the remainder across in order of Salem, Northern Adelaide, Women's and Children's, and in the country spaces as well. And we've had a relatively low number of admissions. It fluctuates depending on how we report out. So it can fluctuate anywhere from around 150 to 190 current admissions, depending on whether we count patients who come into COVID care centres or who come into the ED and have an episode of care. But certainly since the 1st of February, we've seen that increase in children under 12 testing positive, and a slight decrease in the 20 to 29-year-olds. But we're not expecting to see, we are expecting to see that will increase when universities go back. And I will point out, this is the great work, these numbers from Joe Varney from the Royal Adelaide, who pulls together this based on our current numbers and cases, and has done some amazing modelling work for us, separate to the modelling that's being undertaken for SA Health through the University of Adelaide with Professor Josh Ross. So just quite helpful having that real world data that she's been able to map for us based on admissions as well. So as part of that, we can see where we had the border opening, and some of you have probably seen this graph before, but interesting how we're sort of getting this little bit of plateauing happening around those case numbers there. And they're the active case, currently active case numbers that you can see there. And you can see we're sort of really tracking along that curve as predicted, which is our median prediction line for the state. I thought this was interesting as well. This gives a demonstration around what's been happening over the last 4 weeks here in SA, and you can see how you've got that sudden change in the 5 to 9-year-olds coming through, and then those numbers sort of drop off, and you can see then we've got a bit of a peak happening as well in the 30 to 40-year-old age group, which correlates with parents of kids coming through in these numbers, and then a drop off in the 70 plus age group, as we've seen a reduction in aged care facilities impacted by COVID-19. Hospital occupancy, we have a relatively small sample size, so it's a little bit, you can see it's a little bit sporadic around where the numbers are sitting, but relatively stable number there coming along, and you can see that that's dropping off. there's some slight changing in how we've reported some of our numbers, which gives that fluctuation that we've just seen the last few days. But again, coming down those lower numbers, sitting around the 150 mark. With ICU, again, really small numbers that we're seeing now, which is really, really pleasing to see with low numbers of ventilated patients and tracking along that number. So we really want to see that trending down now, particularly over the next few weeks. We don't want to see that number then coming up, which could indicate we're going into a second peak. In terms of the hospitalisations, again, this is just, I find really quite interesting, the age numbers that we're seeing. So we're seeing there are a few happening in the 0 to 4-year-old age group, and then seeing that later on down in the age progression, particularly conscious of the fact, though, that we have seen that decline happen. And we know a lot of this has to do with aged care facility outbreaks coming under control, and great work of rapid response teams into a number of those sites here. I just thought this was quite interesting. I like looking at the other states to see where they're sort of tracking. We all sort of had that really clumped period in January where those cases increased, and we know Christmas would have absolutely had an impact on that. And just to be interesting to see the Northern Territory is really quite fluctuating a little bit, in a little bit of a slightly different space to where we are in the other jurisdictions at the moment. And no doubt WA will see its time as well come up in this case count. So we'll closely track that. I just think it's quite interesting how we saw that all the states that are grouped together and the Northern Territory is just slightly off there. And you can see here again, this is the active cases overall, and per 100,000. You can see again as well that we've just got that area just sitting a little bit higher than where we'd expect the current active cases in the Northern Territory. And then you can see as well for WA just starting to come up there. So in terms of new updates, hopefully that was of interest for individuals. In terms of new updates that we've got currently, we know that there were close contact testing requirements that changed on the 6th of February. And just to touch on that, because we haven't had a webinar since then, this is the first one, is particularly around that change now around rapid antigen testing on 1, 3, 5 and 7, instead of it being on days 1 and 6. And we've moved now to really encourage people as much as possible to get that PCR test, particularly symptomatic PCR test, that initial test, and then on day 6 as well. I can't stress enough, I'm sure Tom will go on about this as well, but can't stress enough, you've got to get PCR tests and get those numbers up so that we can get that really good detection rate happening in the community to enable that early isolation period. The other thing I want to post is educational settings, and we're delighted that we'll have our next RACGP education webinar series for GPs will be on educational settings, because this is such a complex area, particularly around exposure and risk, and we're seeing a lot of questions coming into our team around this, particularly with extracurricular activities. So strongly encourage you to please look at the educational setting testing classroom contact matrices, which are online. And the final area I just wanted to update on was disease characteristics, and particularly what's come out of the latest SONG, the series of national guidelines which are set through CDNA nationally. And these ones that came out a few days ago now are just quite interesting around, particularly around transmissibility and that immune escape. Now, as we're going to see more cases reinfected, which is always a little bit frightening of COVID-19, and the median incubation period as well being that 5 to 6 day period. It's just interesting, particularly around our close contact definition as well, noting that we have that 7 days period there, that we are still seeing that median incubation around 5 to 6 days. It doesn't appear to have come down lower than that. In terms of case fatality rate as well, it is sitting pretty reasonably low. We know at 1.4%, and consistent with the fact that we've seen 35% of, this is in Australia reported, of that case fatality rate has been in residential aged care overall. So that does fit in with our picture here as we see the decline now in aged care presentations. And really booster doses have been incredibly important in being able to reduce down level of transmission in aged care facilities. Just a quick update on vaccine tracking and what's new in the vaccine space. So we know that we've now moved into that 3-dose regime being recognised as being up to date in the air now, which is really, really great news. And the booster dose, some clarity around that not being later than 6 months, ideally 3 months of becoming, within 3 months of becoming eligible should be given. And fantastic to see Moderna being approved now to be given for children aged 6 to 11 as well, which is wonderful news. And just to really emphasise there as well that for children it can be given. We know that it is acceptable to be given at least 14 days apart, but in South Australia, we are still maintaining an 8-week interval between the 2 doses for children here, and 3.7 million vaccines administered. Just in terms of where we're at currently, and this was yesterday's data provided through, just thought this was really interesting around our total percentage of boosters here in the state. So we are sitting at 44.2% overall of the total SA population. I thought it was interesting. And in terms of 16 years and older, it is sitting at 54%. So there's still a bit of work to be done in that space, but noting the fact that some of that population group would have only would not be eligible yet for their booster dose. And great to see that we're over 90% now for 12 plus age group for second doses. It'll be really, really good to see when we hit over that 80% mark for the total South Australian population. Noting, of course, we can't unfortunately give the vaccine to children aged 0 to 4. Just in terms of where we're sitting currently in the weekly vaccination rate by sector, I just think it's quite interesting, but we're always interested in this around where we're tracking in terms of primary care and through SA Health numbers. So you can see that really strong peak in January that we had, and that really strong drive for vaccination, spurred on by the really strong messaging around boosters and also cases here in the state as well. You can see that really good increase when GPs commenced vaccination, that peak in October, and then the drop off, then coming back again when we had the Omicron wave. And again, this is just quite helpful as well, particularly around the booster doses and where we see that projection happening over the next few weeks. We expect the majority of vaccinations here in SA will be administered by Anzac Day based on our current predictions. And that's on the 8-week interval for children, and also the booster doses with people being eligible because of that time interval being up of 3 months post second dose or primary course. And in terms of the paediatric vaccinations from next week, we'll see that surge in second doses being given. And then again, that tracks out really well to where we expect to see second doses being given around that late April time, all of those being given. However, still noting as well that current data is saying that around 45% of eligible children have not had a vaccine. So there is still messaging to be done, particularly for children aged 5 to 11 to get vaccinated. And we know that some of that has been for many reasons, family pressures, different logistical reasons. So we are looking at different programs to try and increase. And this weekend we have our Supervax Family Weekend with different events on in different regional communities and in Adelaide as well, to encourage families to come out and get vaccinated, looking at some of the lessons learned from interstate. All right, so that's all from me. I think I've covered enough in the 20 minutes, but as always, very happy to people to post questions in the Q&A box, and we'll go from there. So I'm going to hand over now to Associate Professor Tom Dodd, who's the Clinical Services Director at SA Pathology. And all of you know Tom does an amazing job, incredibly dedicated to the pathology profession, but very wise words come from Tom. So we're looking forward to this update today. Thanks, Tom.
Terrific, terrific, Emily, and good evening, everyone. So let's see if we can project this here. Now, I don't know what you're seeing. You there, Emily?
We can see your slides. Thanks, Tom.
Good. Great. So it was a bit of a sort of red letter week for us, because we completed 3 million swabs this week here in SA Pathology. The state's done 3.8 million swabs, and we've done 3 million of them. So it took 1 year approximately to get through the first million, and we got through to the second million around the 20th of November, just before the borders opened, and we've done 1 million swabs between the borders opening and now. So as everyone knows, it's been furiously busy, but the pleasing thing is now we're really back in a very good space. All the drive-through points are working extremely well. The waiting times now to get a swab in at pretty much every site is well under an hour. So ease of access has always been critical to getting people to come out and have swabs. I think we're in a very good place now to support widespread additional swabbing as required, as we're going through this little mini surge associated with the school kids. And turnaround times in the laboratory have also come back to where we really wanted them to be. Obviously, things drifted up during the peak in January, but we're now down to consistently under 12 hours. And last night, putting through a fair number of swabs. We were under 9 hours for completing all those swabs. So just looking at some of the numbers over the last month or so, things have really come down. We hit a peak in mid-January around nearly 20,000 swabs a day, and we've been consistently around this sort of 6,000 to 7,000 swabs a day over the last month or so. Actually, in the last couple of days, it's gone up again to just under 10,000. But once again, there's plenty of capacity to manage that sort of volume of testing. I think that probably reflects a rising number of symptomatic school children, people bringing in their kids to get a swab. So very, very steady and accessible capacity for PCR swabbing. And what's been interesting is obviously rapid antigen testing became quite important just to be able to spread the testing workload as we were reaching maximum capacity for PCR testing. But obviously that's come back a bit now, and many close contacts are coming in for PCR tests. So as you know, we're actively encouraging anyone with symptoms, irrespective of whether they're a close contact or otherwise, to have a PCR swab, because obviously it's such a reliable test. So we're seeing good numbers of people coming through for PCR swabs as close contacts, but still maybe 2/3 of people actually who identify as close contacts are asymptomatic as well. So people are making good use of the availability of PCR testing, and the number of people collecting rapid antigen testing has declined somewhat, probably as the PCR use has picked up a bit. So we're just encouraging all those people to make good use of the testing. Emily spoke a little bit about what's happened with children as well, and this is the SA Pathology data, and it sort of matches up very, very nicely with the information that Emily demonstrated. So the bottom line there in blue is the 0 to 10-year-olds, and the next line above that is the green is the 10 to 20-year-olds. And as you can see, really since the schools opened again for term 1 right at the beginning of February, we've seen this steady rise in the percentage of positives in that age group. So that percentage, 25, 26% is the percentage of positive COVID tests per day. So, we're seeing, around that 1,000 cases a day, of which a quarter or so of them are children, primary school age children. And that's been as predicted, and then a little increase, but not too dramatic just yet in the secondary adolescent, secondary school age kids. So rapid antigen testing, there's actually been a lot of use of rapid antigen testing in a very sort of strategic way, I guess. So as we know, it was very important and continues to be for close contacts, noting, as I said before, obviously we want symptomatic close contacts to get PCR tests and not rapid antigen tests. It's still being used through multiple sites across the state to collect these rapid antigen tests. I think we're providing 4 tests now for people to do a little more testing. It becomes a more sensitive test if you do, obviously, tests every second day. Rapid antigen testing has obviously been used quite extensively for staff screening, and we've been involved with FIFO minors and others for a very long time, but the hospitals now are using it, they should be aware, quite extensively for screening of staff, and it's been very effective in picking up both staff members before they come to work, and we even in SA Pathology have diagnosed a number of cases with people having a positive rapid antigen test before presenting to work and keeping them out of the workplace. So I've been very pleased with how that's panned out. That, look, there is a small percentage of false positives, and so if you have patients with a positive result with a rapid antigen test is regarded as effectively a positive result, but I think it's probably pretty sound clinical advice actually for people to go and get a PCR test for confirmation is certainly a requirement if you're going to have therapy, and I guess we'll hear a little bit more about that for the oral drug shortly this afternoon. And also the health has been really using rapid antigen tests a lot to assist with prompt diagnosis and management of a number of communities. It's been widely used in the Aboriginal communities where there's been some outbreaks in the northern part of the state, and also providing rapid antigen tests for other vulnerable groups in the community with quite effective outcome as well. It gives you that immediate result, and then you can use PCR for confirmation. So what's been happening with the whole genome sequencing? So this is kind of a pretty graph that just shows the really how infectious and how quickly Omicron has replaced Delta. So that the borders opened, as we know, in late November, and there was a modest amount of Delta still being transmitted in the community, but very rapidly that's been outstripped by the original Omicron variant, the BA1, which continues to be dominant here in South Australia, but sort of mid-January, late January, we started to see the beginning of the BA2 Omicron variant. So we've now had about, I think it's 115 cases of Omicron BA2 variant diagnosed here in our whole genome sequencing in SA Pathology. Obviously doing 1,000 or several thousand cases a day, we've stopped doing whole genome sequencing on every single case, but try and get a good sample across various groups. Obviously people in hospital typically all have whole genome sequencing, people in ICU certainly do, and various different clusters, we've got pretty good sampling. So I think it's fairly representative of what's happening. So the BA2, as you would be aware, does appear to have a higher transmission rate than the BA1 variant of Omicron, the original Omicron variant. So in some countries, they are reporting significant replacement of BA1 by BA2. So it'll be interesting to see how that pans out here in South Australia in the coming weeks. Most of these cases have been diagnosed in international travellers arriving with positive results, but I guess we'll start seeing more community transmission of BA2. The literature, I think, is still evolving very much on what that means clinically. There's some preliminary data that suggests that it's obviously more transmissible, but probably doesn't cause an increase in severity of illness or hospitalisation, but it's early days, I suppose. So we just have to see how that plays out in the coming weeks. So we're obviously looking very much about what happens next, and thinking about particularly if we have the tail of COVID merging with an open border with people bringing in influenza from the Northern Hemisphere, so that we've got active planning in the laboratory now to be able to do a combined COVID and influenza PCR test in a very similar way to what we're currently providing with COVID only. So that drive-through model with the patient coming through, having a swab, rapid PCR turnaround time, and then being provided potentially with a result for COVID and a result for influenza as well. But what I think is incredibly important as we start moving back towards conventional models of care where patients are being actively managed, obviously, by you folks, general practitioners out in the community. So we will have a big capacity for clinician-ordered full viral panels with all the other viral viruses, rhinovirus and adenovirus and so forth, and pertussis as we move through into the winter. What we're really working towards at the moment is a a very neat, seamless end-to-end process. So electronic ordering will really facilitate that, I think, for GPs, possibly being able to sort of order, and then patients potentially come through, get their swab, and then the result comes back to you as the managing clinician to provide the care for the patient with a full viral panel. We think we can probably do 6,000 or 8,000 of those full respiratory panels a day. So I'm very optimistic we'll have a very sort of neat and clean way of providing that service, and then you folks are back managing your patients in the sort of way in which we would like to move things forward. What of course that'll require is the ongoing commitment to these large drive-through facilities, and I guess we'll just have to see how the public health response pans out in the coming weeks. And finally, in a rather excited way, we've moved along with the COVID detector dogs. Originally, they were all about detecting COVID in international arrivals. But where we are now is actually, I think, even more exciting. So there's now the Adelaide University have now trained the dogs to do direct detection from scent rather than sweat. So the dogs can now sniff with their amazing olfactory sense and detect positive cases with incredible sensitivity and obviously immediate response. And the plan is in the coming couple of weeks for the dogs to start working in the Lyell McEwen ED department as a way of screening. So we think that'll be very interesting and exciting. And if it works well, and you can see they're very friendly, mostly Labradors, and there's a nice Cocker Spaniel as well, there's a possibility they might have a role in schools, I think, and be very well tolerated. No more taking rat tests. The dog sniffs the kids as they arrive, and if their sensitivity is as good as we believe they are, I actually think this could be really exciting. So that's where we've got to at the moment, and by far that's the most exciting part of the whole experience for me, is working with Adelaide University with these dogs.
Thanks, Tom. As always, very entertaining, and thank you for including around the detector dogs as well. We know they're awfully cute, but it's really interesting to see where we're going to see some changes in that space moving forward as well. All right, now we'll just close off your screen, Tom. Let's have a, and then we'll progress on. We've had a couple of questions that have come through specifically for you. The first has been around, we still seem to get quite a lot of questions around serology in this space, Tom, particularly around serology post-COVID, and people now sort of wondering, should I go and get my booster dose if I've got, a high immune response post having had an active COVID infection? Are you seeing many requests coming through for serology at the moment? And is it still possible to get the two readings in terms of knowing if someone's had a vaccine or if someone's had a COVID infectious exposure? Thanks.
Yeah, so look, the serology testing's absolutely available, and the serology does distinguish between infection, post-infection versus post-vaccination. So that there's antibody for the spike, which you see post-vaccination and post-infection, and then there's a separate antibody test for the nuclear capsid, which is seen in the post-infection state. So I think the sound advice is that, though, irrespective of whether you've had an infection or not, you get vaccinated, because it gives you a level of protection against reinfection.
Yeah, that's a really good point. Thank you, Tom. And then the other questions that we've had come through in the chat are just around this ongoing issue with negative, having a negative RAT or a positive RAT and a negative PCR. We see this come through quite a bit. Just if you've got any additional words of wisdom you wanted to add into that conversation. Thanks.
I think rapid antigen tests are actually a good test used in the right clinical context. They lack that sensitivity and specificity. There are false positives, but they're not a huge percentage, and it's probably satisfactory to regard a patient positive on the basis of a positive result, but you wouldn't be actively treating them with any of the medications without a PCR confirmation. But I think the thing is, if someone's got COVID-compatible symptoms and they've been in a household with other people with COVID and their rat's positive, they're positive case. You know, if it's out of the blue, they don't have any symptoms and they're rat positive, then the sound advice would be to get a PCR test, which is extremely accessible here in South Australia. It's such a different situation elsewhere, you know, interstate and so forth. And so I think, you know, the clinical judgment and the clinical context is incredibly important. Serial screening by rat is actually very valuable, I think, in sort of, you know, if you're trying to manage outbreaks in nursing homes and so forth, and you know that's a very helpful test. But a one-off test on its own doesn't have quite so much value, I think.
Yeah, no, that's excellent. Thanks, Tom. And certainly aligns with our change now in close contact testing, moving away from that 1-6 to that 1-3-5-7 regime, particularly then to get that serial test as well. And we've had you know, conversations come through around, particularly for rats, and I'll do it once a week. There's just not the evidence to do once a week rat testing, particularly in healthcare settings. You really need to be looking at every second day or every day testing. And certainly we've implemented every second day across a number of our healthcare sites, including in quarantine spaces as well. So thanks, Tom. I'm going to get you to stop sharing your screen now, if that's okay, Tom, and we're going to move to Dr. Jenny Gould to give us an update on where things are with the GP assessment team. And words of wisdom, Jenny, as always, we'd appreciate of tips and tricks you have for our primary care practitioners. Thanks.
Let me see. Well, hello, everyone. Won't let me share. Good on it. Thank you for joining us this evening while I fiddle my technology. It's hard gig to follow Tom and his cute dog picture, nonetheless. But I will. So I had actually thought that there wasn't so many fabulous speakers on tonight, so that I would have to cover a lot more things. So I think there are a number of slides we'll be able to zip through. Unfortunately, I can't share my screen for some reason. You can't see that, can you?
No.
Let me try again. Share screen.
Oh, good. We can see it, Jenny. Fabulous.
Oh, good. Okay.
Thank you.
Great. All right. So let's get started. So Omicron, Tom's already covered this far better than anything I could say, but it's really that the Omicron is, and I'm sure Ranji Nelson, who's speaking later, will also talk to this, its ability to be immunoevasive, and so that we have greater spread. But immunology is a long time ago for me, so I'll leave it there. But really what this means is, this is why we've seen that reduction in efficacy of the vaccine, and the really, really huge importance of boosters, which is where GPs can play such a fabulous role. And Emily has put up the vaccination data, and although it's sort of moving in the right direction, there is certainly room for it to continue to move. So as GPs out there on the ground, you guys are in prime position to be encouraging your patient communities to vaccinate and to have that booster and stress that importance. So this is a slide that I have borrowed from Emily in one of her many fantastic talks. But so this is what we are seeing, as you're all very aware. With Omicron, we see about 98% of patients who are very mild and can be managed very safely by you fabulous GPs in the community. And so this is that low risk pathway, which we're very familiar with, and we've got support in that for these patients with Health Direct, and obviously encouraging people to liaise with their usual GP. And of course, things can be escalated through the cricket team or the COVID response care team. So most of the patients who are COVID positive will fall into this pathway. That small group of medium risk patients is the one where my team, the GP assessment team, and I'd like to do a shout out and thank them for being absolutely amazing over the last almost 2 years now. We've really increased our numbers and we're over 100, I think, in our team now, covering this small percentage of patients. And anyone who would like to join the GPAT team or who thinks they might like to, absolutely, just reach out and let me know. Happy to have new fabulous South Australian doctors on board. And of course, we have the high risk pathways, which are our hospital-based care predominantly. And we also have our COVID care centres, and that's a very exciting thing this evening we can talk about, in that GPs now in the community will have access to at least a couple of those COVID care centres moving forward. So how does this all look? Again, I think this is another one of yours, Emily, but we've got the Royal Adelaide, which was the centre of all things COVID and still kind of remains that way, but we've got Lyell McEwen on board. Flinders has taken the lead in obstetric care for COVID positive women, pregnant women, and we've got our paediatric pathways through the women's and children's, including COVID kids, and of course there are residential facilities in aged care and disability. We have fabulous regional and rural centres set up throughout South Australia, and I'm sure for those of you who've been on recent webinars and heard Carolyn Fagan speaking, these are really working well out there for our rural patients and our Aboriginal communities, which we've set up some facilities locally in Ceduna and Port Augusta, so patients who are COVID positive can stay in their local area. So lots of busyness in the COVID world. So where do you fabulous GPs fit in? And I think GPs are fundamental to healthcare, and that doesn't change in this environment. So again, I see our role as really encouraging vaccination, but not just COVID, although very much COVID, but other vaccines as we move into winter and flu season, etc. Of course, it's really important to focus on patients' usual medical care and their preventative care, not just to get lost in the world of COVID. There is other things that we need to do to maximise people's well-being. If we have patients who do end up COVID positive, then it's important for those low risk ones that we've talked about. The large majority of the COVID positive patients can be managed by GPs. It's really similar, well, our viral illness, and in Omicron we've been fortunate that we haven't seen quite that severity of symptoms across the board that we've perhaps seen with Delta and other variants. So it's really about supportive care that you're very comfortable in doing with viral illnesses, and recognising those people at risk, you know, people with underlying respiratory disease, and identifying those that are more likely to be at risk of deterioration. And I think we've talked about that a lot, but I have got a slide that just refreshes us in that area. It's also important to monitor these people, liaise with other healthcare programs that they might need to be involved with, renal or other chronic illnesses and pregnancy pathways, and refer them for face-to-face assessment if needed. It's really important to look out for red flags, and these red flags, remembering just because you're COVID positive doesn't mean you can't have another comorbidity. So these people can still have cardiac chest pain, they can still have, you know, cerebral vascular events, etc. So we need to manage the same acute priorities that we would in general practice, but also being mindful of those priority 1 or high risk scenarios that we have in that COVID space. So patients who are presenting with shortness of breath or describing shortness of breath, and if they're one of the groups that have access to oximetry in the community, they're getting saturations less than 95%. So these red flags that we've talked about over the past few months, The specific considerations which we need to think about, different from other viral illnesses in general practice land, is the monoclonal antibodies infusions. Sotrovimab is really the player here in the Omicron variant, and the oral antivirals. And I'm very grateful that we've got some experts to speak in this space tonight, and you don't have to have me bumble my way through it. And of course, in pregnancy, we need to think, or postpartum, we need to think about VTE prophylaxis, because of course, COVID is already places people more at risk. And if you've got pregnancy, that increases that baseline. And I think the one that, you know, is really, really important throughout all of this is the mental health support. Living in a community with COVID, which is still a relatively new thing and has changed our lives extremely, is really difficult. And then getting COVID can be an enormous stress for people. So GPs are absolutely fabulously placed because of the relationships they have with their patients. You're able to tap in and provide that support that you already do so very well. How do you do all of this and minimize your risk? And I guess, you know, was a lot of apprehension and still some apprehension about face-to-face care. And I think, you know, that's been clearly documented now with the COVID matrices put out by SA Health. But if you're fully vaccinated, you're wearing the appropriate PPE. If you want to look to limit your face-to-face to under 15 minutes. So if you think you need to do a long consult, some of that can be over the phone, and you can just bring the patient in for an examination. You can limit those people accompanying, so you don't have to have mum, dad and the 5 kids coming into your consultation room at every visit. And of course, if you've got someone who's SCOVID or COVID positive, there's telehealth and those other resources available. If you're needing patients to be assessed face-to-face and, you know, you want to do that in your full PPE, well, good on you. But otherwise, there's lots of pathways that can support you in that. And I think the big fear was always around exposure in people's general practice setting and what that would mean. And I think the matrix really explains that well. And if you are fully vaccinated and using the appropriate PPE, you're very well protected in that space. What resources are out there for you to provide the amazing care that you do? Well, hopefully there's lots and more as we move forward. So we have telehealth and video calls. We have COVID care kits, which are delivered to higher risk COVID positive patients in the community so that they can monitor at home. We have remote monitoring devices, the ICC TNet, where certainly patients who are higher at risk or rural and remote patients can have that additional support and monitoring with the video facility available to do consultations. There are the virtual care services like the child and youth virtual urgent care service at the Women's and Children's in ED. There's Health Direct, there's Health Pathways, there's lots of pathways, lots of effort that's gone into generating referral and pathways. So as we've already talked about this pregnancy through SAL and the cricket team, the GP assessment team, the Medi hotels, the COVID care centres, which I think is really exciting, as you can now refer in directly to those local facilities on the ground in some of these Aboriginal and Torres Strait Islander areas. We've got the GP shared care, obstetric shared care program, which recently ran a webinar looking at providing resources and support for our GPs delivering pregnancy care in this COVID positive space, and the guidelines in pregnancy that have been recently released. And of course, there's the remembering the MAB online application for patients who are suitable. So more than enough to keep you busy on top of your usual busyness. So here we can see, which the slide I think we've all seen lots of times, the risk factors that make you more at risk for disease deterioration, which is slightly different to the risk factors we need to identify in someone who's eligible for MAB. Oops. This is, I know, Emily, this is one of your favourite slides and you've already talked to it, so I won't talk to it except to say, as people progress through this, we have additional supports available. So we have the maternity pathway, the COVID care centres, the hospital transfers, and we can escalate through the CRCT to GPAT and the COVID kids. And of course, we have the other pathways like Health Direct, etc. So the COVID care centres, we have 3 in metropolitan Adelaide, one at the Royal Adelaide, which is a 7-day-a-week facility and sees patients who are COVID positive face-to-face over 16 years of age. And Sarlan, who is also 7 days a week and sees COVID positive patients who are over 18 years of age. Narlan at the Lyell McEwen is still providing infusions at the moment, but they are doing 2 days a week of face-to-face assessments, but that is still a referral process through the cricket and GPAT pathway. So if you've got patients that in that region, on Tuesdays and Wednesdays, there's medical services out at Narlan for face-to-face assessments. But at Carlin and Sarlan, as of yesterday or today, only recently hot off the press, you can refer directly in. Now, these slides are borrowed from or sent to me by Eleanor Wilson, who is the medical lead at the Sarlan COVID Care Centre, but I think this largely applies to across them all. So I've just included in here what they're offering, which is a face-to-face review. They can do, the examination, investigations, etc. That you would expect and want to do if you were able to see your patients face-to-face. They can support beyond just that one-off consultation and have interpreter services and other support services available. They will also obviously liaise with you as the referring GP. Exclusion criteria, they are not seeing what would be priority 1 patients. These still need to go to ED. These ones that we talked about, patients needing resuscitation or oxygen saturation less than 95%. They don't see children. There's a dedicated pathway through for those. But otherwise, they can pretty much see just about everything else, and they're headed up by GPs. GPs are everywhere in this COVID space. So to refer in, although this talks about Sarlan, it will be very much the same at Carlin with the different phone numbers. You need to refer a patient, you need to phone and speak to them. Patients cannot just present. It's not like an ED, although we not being want to encourage COVID positives to just present to ED either, but they absolutely need to be booked in. Transport can be arranged, and they will be given a time and instructions of where to come, where to park, how to get in, all of those things. And once that service is completed, they will be then managed appropriately, returned back to where they came, be at home or a Medi hotel, or if they need to be admitted, then that can be done directly. So this is all very new, and I'm sure if you reach out to either of those COVID care centres, they will provide all of the resource materials that the GPs in the community need. The MAB referral is something that I would really like to plug, that and vaccinations, if there's only 2 things you remember from my talk. So I think we're probably under picking up perhaps people who are eligible for MAB. And I think as GPs in the community, you are absolutely the people to know about this. You know which patients are in those at-risk categories. And if they turn COVID positive, you already know in advance that those are the people that are likely to be eligible, and that you can escalate that. So really, all you need to know about a MAB is if you go to the website, and it has all the information about eligibility, and it has the actual online referral form which you can complete, and as you complete it, it basically sort of tells you who's eligible anyway, and then you would send that in. And now, just because you've referred them doesn't mean they will get a MAB, so it's important to let patients know that they're being considered for if it would be helpful for their circumstances. But yes, and if you're unsure, you can speak to an ID consultant, or if you're unsure, then put as much clinical information in the referral as you can, and send that in, and they can contact you need be for anything further. Remember always to put your name, your email, your phone number. It does ask for your prescriber number, and I know people have been quite anxious that that meant that they were prescribing and hence would have responsibility for the consent. That's absolutely not the case. The reason for your prescriber number on there is that this is a public website, and it's really just about identifying that medical professionals are referring. The consent and the prescribing will be done by the COVID care centre, be that metro or rural, that is going to prescribe to administer the MAB. So this is a slide that sort of, you have to think, Jenny, a bit. It's a bit confusing, but I think, and I won't go through this because we've got Ranji and Katie on who will talk about this stuff far better than I can. But at the moment, this is just trying to outline the pathway for Sotrovimab, which is still at the moment our big referral pathway, and then how we might move towards oral antivirals. So this talks about the risk factors for those people who, you know, if we identify someone who's not completely vaccinated or unvaccinated, or immunocompromised, or having immunocompromised condition that negates their vaccine, the risk factors that we would be looking for. And I think the key changes in here is the age of above 60, the obesity at 30, and there's 35 for ATSI patients. And then the addition of MS, motor neurone disease, myasthenia gravis, and Huntington's, as well as Down syndrome into this group, because although they might not strictly be immunosuppressive conditions, we have seen people do quite poorly with those conditions. All right, busy slide. This, yes, I'm going to drill you on this at the end. No, this is just really to show you all of the immune compromising conditions, and that would be on the website. You would be able to access it. You're not expected to remember it. The medications that are immunosuppressive and therefore would meet criteria. Again, you don't need to memorize this, it's on the website. So when you're thinking about MAB infusions for COVID positive patients, including pregnant women, we need to think about, are they eligible? So they need to be COVID positive, and even if they are RAT positive, they will need that confirmed by a PCR. It needs to be less than 7 days, and they need to not be on oxygen therapy. Or if they're usually on oxygen therapy, they haven't got an increased demand for oxygen therapy. They've remained stable. They need to either immunosuppressed, and we went through those lists, but that is, as I said, on the application form, or they're unvaccinated or partially vaccinated with a risk factor from that list I gave you. So what is the criteria now for partially vaccinated or not completely vaccinated? Really, that means you've had only none or one vaccine dose, or your second dose has been less than 2 weeks since you've had it, or greater than 3 months. And that is a new criteria, the greater than 3 months, or it's less than 7 days since your booster. This just puts that for those people who like a visual flow chart, but basically they're picked up, the online forms completed, they go to the fabulous data's who work their way through all of these and liaise with the ID team and obstetrics. All pregnant women are referred, and then they're allocated to a COVID care facility or an infusion centre. And so the 3 that we've talked about in metropolitan Adelaide, but of course there are many and increasingly more and more who are coming on board in rural and remote. And then they have the pre-booking infusion counselling and consent. Then if they've not had their rapid PCR, the PCR positive, they definitely need it, as Tom said, before they're given it. And then they will be, the infusion will be take place at the identified centre. It just shows you some of the metropolitan and some of the rural and remote areas that are doing MABs. When we think about pregnant women, just to plug in there. So COVID positive women, the plan is to birth at Flinders. If they present to one of the other hospitals and found to be COVID positive, they may well birth at that hospital, but that would need to be done in liaison with Flinders. Within that, Women's and Children's is still providing care for cardiac babies and MFM patients who need to birth. If you want a face-to-face assessment for your pregnant women, more than 16 weeks, with any issue, they go to Flinders, or under 16 weeks, if it's pregnancy related, it's Flinders, or if it's not pregnancy related, then they can be seen at the COVID care centres. And if you are just wanting to discuss a patient who's pregnant and not sure whether they need to be seen, or you're not sure about a MAB or VTE prophylaxis, then phone the hospital where they would be booked or zoned to birth. With pregnant women, not only do we need to think about MABs, we need to also think about their VTE risk, and talked a bit about that. That's already higher. So we have a process for assessing these. There's a scoring sheet, and then if you generate a score for these patients, that actually means that they meet criteria for potentially treating, then we would suggest you contact the birthing hospital and discuss that, because they would need to start on enoxaparin, and that might be prescribed by you as the GP or through the hospital. But that's something that you should do in consultation with the obstetrics team looking after them, remembering that Clexane is weight dependent in how we assign dose. And with any medications, there's contraindications. If patients need that to be delivered when they're COVID positive administered, and they can't self-inject, and there is some online training, then that can be organised through hospital in the home or the MAU to go out and assist those patients. Here's the obstetric contacts at each of the hospitals in Adelaide. And I've also put on here for the cricket team, the COVID response care team, their contact for the GPs, and also the number we give to the patients if they need to escalate. Please be mindful not to give out the clinician phone number. It just means it's very difficult to get through if patients are ringing on that line as well. Okay, I am just going to say with the oral antivirals, I'm going to leave that to the experts and move on to the next slide. I think this is, I think we're all very familiar about clearance, but this is still one of the things that patients ask us mostly. When can I get out of isolation? So we've got that day 0 being the day of their positive test, and they need to complete 10 full days and can clear after midnight. On that 10th day. They do not need a test to return to work. And if they're still symptomatic, then they should actually really remain in isolation and then connect up with you for telehealth. Okay, so that was a lot of a whirlwind through all things COVID in the community. I just wanted to say a huge thank you, our community GPs and everybody working so hard in this space, and especially my GPAT team. But I think GPs are the absolute cornerstone of community care, and COVID is no different. And I think we've proven ourselves over and over and at being essential and providing excellent care. So remembering, vaccinate, and think about MAPs for all of those people that might be eligible, and use those additional support services like the COVID care centres. So thank you, everyone.
Thank you, Jackie. Thank you, Jenny. I meant to say, I was going to say, Jackie, Eleanor, and the team up at Nylund do a fabulous job in the COVID care centre. So I think if we can try and encourage referral in, that would be very much appreciated. Given the fact that given the fact that we know that we want to see that transition over to usual GPs being able to access care for their patients. And as I mentioned as well, we've also got the GP respiratory clinics as well. 3 out of the 4 are very happy to see COVID positive patients based on their infrastructure that they've got in place. And we know that the team at GPAT do a fabulous job answering your questions and really help navigate care for your patients as well. So we're really, really pleased now to have Dr. Ranji Nelson, who many of you have seen from previous webinars, but also is really the expert in the space of infectious diseases, particularly around, we know, with the oral therapies. And Ranji's been doing a fabulous job also leading long COVID work here in the state as well. And we know that's going to be a really topical area moving forward. And we're hoping to have Ranji present as part of our educational series at the RACGP around long COVID, particularly in more depth around those allied health involvement and that multidisciplinary team. But tonight, Ranji's really going to focus on the oral therapies and the sudden shift we've now seen when they all turned up at the RA a few weeks ago, with very little understanding as to how they were going to roll out in practice across the state. And now we are seeing them in our aged care facilities. So it'd be great, Ranji, if you're able to step through where we're up to, what we need to be conscious of GPs, and also we've got Katie as well, Caitlin Wallace and Naomi Burgess, our chief pharmacist, as well, part of the panel. So questions, please send them through and we'll pose them all to everyone as well at the end. So thank you, Ranji. Really, really pleased that you were able to join us tonight. So thank you.
Thanks, Emily. Can you see my slides?
Yes, perfect. Thank you.
Right, so I'll get straight into it. So I'll touch a little bit on the treatment for moderate and severe disease, and then go straight into the oral antivirals for mild disease. So I think all of you by now would be familiar with this picture, which illustrates the pathophysiology and natural progression of COVID-19. So you have that early infection phase where there's a high viral load, patients are highly infective at that stage, and often patients have mild constitutional symptoms, fever, dry cough. With Delta, we saw very severe sore throat. Often they're lymphopenic. We use the degree of lymphopenia as a marker for likely progression. And this is the phase where we would consider using medications that target the virus directly. And that could be in the form of antivirals, both IV and oral, or the monoclonal antibodies against the spike protein. Then as the infection progresses, the host inflammatory response starts setting in, and it starts with, that's when patients start getting hypoxic. You start seeing infiltrates on chest x-ray, CT scans, and you might see some LFT abnormalities, and the inflammatory markers start going up. This is the phase where we start looking at introducing anti-inflammatory agents, and dexamethasone, which has been shown to have significant mortality benefit, is our first line of treatment for moderate disease, along with remdesivir, which is an IV antiviral agent. Remdesivir also has been shown to be effective in that early phase. The problem is it is an IV medication given once a day over 3 days, and hence it's not practical, and world over they haven't been using it in that phase, but really only in that moderate phase once patients get hospitalized. Then patients move into the hyperinflammatory response phase, by which time the virus is no longer the issue, it's really the host's immune response, and you start seeing more worsening of the inflammatory state, both systemically as well as with respiratory symptoms. With Omicron, we've seen that it's predominantly a respiratory failure rather than multi-organ and systemic disease compared to Delta and Alpha. This phase, the inflammatory markers start going up: CRP, IL-6, if it's being monitored, D-dimer, ferritin, and procalcitonin. And then you also keep, D-dimer is also another useful marker, both as an inflammatory marker as well as very high D-dimers could also be predictive of pulmonary thrombosis as well. By this stage, if they've progressed despite dexamethasone, then you'd start thinking of using the more stronger anti-inflammatory agents such as IL-6 inhibitors, and we use tocilizumab and sirolimus, and then JAK inhibitors, and the one we use is baricitinib. So for that early inflammatory phase, we have dexamethasone, remdesivir, baricitinib, the JAK inhibitor, and sirolimus. We don't use, there is some good data that Veg and Cove or the combination of monoclonals could have been beneficial in that stage, but we know that it doesn't work against Omicron, so that's no longer recommended in that phase. Dexamethasone, as I said, has good reduction in mortality when it's introduced at that phase, and most of our patients who come in mildly hypoxic do tend to respond to dexamethasone. The hyperinflammatory phase is when they progress despite dexamethasone or and remdesivir. And then depending on how severe they are, if they're mildly, if they're still on the ward, still not likely to get intubated, we consider JAK inhibitors like baricitinib. On the other hand, if they are peri-intubation and in ICU, then we tend to use tocilizumab, which is slightly more efficacious in that once they're that sick. But probably what we'll focus on during this afternoon's talk is really early infection treatment. This is really indicated for mild disease, which basically is for patients who are either asymptomatic, who have mild symptoms, who are not on oxygen. We have two groups of medications available. One is the monoclonal antibodies, sotrovimab and Ronapreve, which we no longer use, as I said earlier, because of the lack of efficacy against Omicron. And then antivirals, two oral antivirals, Molnupiravir and Paxlovid, which is a combination protease inhibitor, as well as remdesivir, which is intravenous antiviral. So we know that risk factors, as Jenny had pointed out, all those risk factors do increase the risk of mortality and hospitalization and the requirement for ventilation. And the more risk factors you have, the higher the risk of progression of disease to severe disease. So sotrovimab is a recombinant human monoclonal antibody. The benefit of sotrovimab is that it actually targets a highly conserved epitope on the spike protein, and hence its ability to have withstood all the different variants over time. There is some doubt about whether the BA2 variant may have less efficacy. It might have less efficacy against BA2 variant, but I think we'll just have to wait and see, watch that space. It's indicated in the first 5 days, which is where the studies were done, but we know that it works within the first 10 days if you're not on oxygen and have risk factors for progressing to severe disease. We have, in Australia, most states use a 7-day period during which you have, from the time of onset of symptoms, during which you have to administer it. So it's indicated for people who are not vaccinated, who are partially vaccinated, or who are immunocompromised, irrespective of the vaccination status. The advantage is it's a single infusion over 30 minutes. There is a requirement for a 60-minute post-infusion observation because of that very, very small risk of infusion reactions. It's touted as 2%, but we are yet to see one. And generally, world over, it's actually the number of infusion reactions has been extremely small. So it's quite a safe medication. There is a recent study that just came out that showed that intramuscular administration is non-inferior to intravenous. And there is, so the company has actually submitted it to TGA for approval for intramuscular use. What that would do is it would enable us to reduce that whole period of infusion from 60 minutes to a stat dose, followed by 30 minutes to stat dose intramuscular, followed by 60 minutes infusion. And it's also quite likely that we would be able to reduce the observation period to 30 minutes once we have a little bit more data. It doesn't require 2 injections, which is where it's, it could be quite painful, but it is useful when we are administering the infusion in aged care settings or as hospital at home. And there is, you don't have the luxury of waiting for 1.5 hours to administer the infusion. Comet-ICE was the trial that demonstrated that it had an over 80% relative risk reduction in hospitalization or death. Molnupiravir is the oral antiviral. It's a nucleoside analog. What it really does is it incorporates using RNA-dependent RNA polymerase, a mutation into the RNA, and then creates an error catastrophe and prevents it from replicating. It's got broad activity against many coronaviruses. Move Out trial was the index study that looked at the efficacy of this drug. 750 patients, non-hospitalized with at least one risk factor for progression and not vaccinated or partially vaccinated. It was given within 55 days of symptom onset, and hospitalization relative risk demonstrated a relative risk reduction of hospitalization and death by 50%. At which time the company stopped the trial, but they continued to recruit, and then it actually further showed a further reduction in efficacy to around 30%. So this is not as efficacious as sotrovimab. There were no deaths in the treatment group. It is 200 milligram pills, which capsules, which you have to take 4 in the morning and 4 in the evening for 5 days. It's not recommended for pediatrics because of concerns of bone and cartilage growth. It's not recommended while breastfeeding, and there is for 4 days after the final dose. And it's also, there is also requirement for males to practice contraception for 3 months after use because of its ongoing presence in sperms. So it's contraindicated in pregnancy. There is some animal data showing teratogenic effects. The advantages are that it's there's very little drug interactions, and there's no dose adjustment required in people with renal or hepatic impairment. Paxlovid is a combination protease inhibitor. Now, many of us would be, not sure what's happening to my slides. Yeah. So protease inhibitors is something we've used for a long time in the HIV population, and often they are used along with a booster, and ritonavir is the booster. So it's a CYP3A4 and a CYP2D6 inhibitor, which enables us to increase the levels of the protease inhibitor. So in this case, the protease inhibitor is nirmatrelvir. It's a mouthful. And it basically acts against the main protease, which is required to cleave the big viral polyprotein into smaller functional proteins, and thus prevents on replication of the virus. Again, like molnupiravir, it has broad activity against all the various coronaviruses. EPIC trial was the phase 2 and 3 trial, which demonstrated efficacy. And again, like the other antivirals, it is given within 5 days of symptom onset to non-hospitalized patients with who are not on oxygen, who have risk factors for progression. And this actually showed, just like sotrovimab, a significant relative risk reduction in hospitalization or death of 89% if it was given within the first 3 days. And there wasn't much of a drop if it was given within 5 days. So it's still got an 88% risk reduction, relative risk reduction in hospitalization and death. Again, no deaths in the treatment group. There were 10 in the placebo group. It's got slightly more adverse events than molnupiravir. It's got some GI side effects, but probably and headache and so on. But probably the most important thing is its drug interactions. Now, dosing, it comes in packs of 3 tablets. So there's 2 150 milligram protease inhibitor, which is, so it's 300 milligram dose in the morning, along with 100 milligram ritonavir. They come as 1 pack, and then a similar pack in the evening. So it's 300/100 BD. The problem with this drug is really, it's one, the requirement, it's contraindication in severe hepatic disease. It's still, you can still give it in mild to moderate liver disease. It's contraindication in pregnancy. This is largely mainly not because of teratogenic effects. It's really because lack of data and probably some animal studies showing some reduction in fetal body weights. And there's not a lot of data in pediatrics. In the US, it's authorized for more than, for patients aged more than 12 years of age, at least if they weigh at least 40 kilograms. The problem is, again, with renal failure, it's contraindicated if the creatinine clearance is less than 30, but between 30 and 60, you have to dose adjust. So you have to halve the dose of the nirmatrelvir, but retain the same dose of ritonavir. So where you have that pack of 2 150 milligrams, you take 1 nirmatrelvir out of that pack and give it with the 100 milligram ritonavir, and the same thing in the evening. So that's where, if you have a patient who might find it difficult and you don't have the ability to create a blister pack, this could be a little complicated for some patients. But probably the most important thing is the contraindications because of drug interaction. So as I said earlier, it's a CYP3A4, CYP2D6 inhibitor. So any drug which uses these enzymes as a substrate will be contraindicated because it can increase the levels of a number of these drugs, especially things like anticoagulation, anti-epileptics, etc. So Katie has done a wonderful job putting a list like this on the website with the guidelines, but also it's also on the referral form. So there is a tool, the University of Liverpool COVID interaction tool, which we've got a link there for you to actually link into that tool, and then you can put in the names of the medications the patient is on and this particular drug, and will spit out the drug interactions. There's also a group of drugs that could interact by reducing the level of the protease inhibitor as well. So those drugs that would also be relatively contraindicated. So we've got three lists of drugs, ones that are contraindicated because they're substrates, one that because they affect the enzyme and can affect the protein, the antiviral levels. And then there's a list of drugs that commonly used drugs that you could use safely as well. The Liverpool website is quite useful. It also gives you added information about whether you in certain cases, whether you can hold a drug, and if you have to hold a drug, how long you have to hold it for, whether dose adjustments can be made, etc. But by and large, I think if they're contraindicated, they're likely to be contraindicated because we only have a small window of 5 days. And by the time most of these patients come to you, they probably already will be day 2 or day 3. So if they're contraindicated, we probably wouldn't be able to use it. So in summary, we've got 3 drugs which are highly efficacious: the Paxlovid, which is the protease inhibitor, sotrovimab, and remdesivir, which we can't use because of the administration challenges of giving it an IV medication over 3 days. And all 3 of them have excellent efficacy in that early disease phase. And then we've got Monopyravir, which has got a 30% efficacy, and hence would be our second line option if you can't use the other 2. So advantages, so Molnupiravir can be used, is generally only recommended in older adults and not in pediatrics. They all have to be, the oral antivirals have to be started within 5 days. The sotrovimab, even though we know there's data for 10 days, we have to start it within 7 days. We're not using remdesivir in that early disease. We've got 2 oral antivirals. We've got sotrovimab as our IV antiviral as an option. Sotrovimab is a single infusion. Oral antivirals are for 5 days. The first 3 are highly efficacious. Molnupiravir is not that efficacious, but advantage being there are no drug interactions. Paxlovid, the problem being there are drug-drug interactions. And all of these drugs at the moment, we have limited supply because we're getting them from the national stockpile, but I'm sure there will be a time when it will be available on the PBS and you'll be able to prescribe it. By then, hopefully you'll be quite comfortable using this drug. What has Omicron done? So Omicron is a variant which has a number of mutations, over 35 mutations. And what that has done is, as Jenny had said, it has created this ability of the virus to evade immunity, whether it's natural infection immunity. So you have a high chance of reinfection. As Emily pointed out, we are seeing a number of patients getting reinfected. It is more transmissible, but transmissible mainly because of its ability to evade immunity. And it also is more resistant to vaccine and infection-induced antibodies, as well as it's become resistant to some of our previously available therapeutics. Now, it's this graph from a beautiful Danish study, which looked at transmission within households, shows very clearly that it is much more transmissible. But as you can see in this table, that transmissibility is much higher in the group that is vaccinated. So as your vaccination goes up, the transmissibility goes up. So again, indicating it's not so much the transmissibility, it's really the immune evasiveness that makes it more infective. What has it done to our therapeutic options? So as far as monoclonal antibodies go, it's actually taken out most of our monoclonal antibodies. We only had Ronapreve available to us. That's now not efficacious. The ones that are currently efficacious against Omicron are sotrovimab. There's an Adagio product which we don't have called adintrevimab, and Evusheld, which is a combination of these 2 which also should be available to us at some point in time in the near future, more as a pre-exposure prophylaxis. What has it done to the antivirals? The same thing. As you can see, Omicron variant hasn't really affected the efficacy. This is mostly from viral culture studies as well as from neutralizing antibody studies. There is quite good retention of efficacy against Omicron. There is some data, as I said earlier, coming out that maybe very small studies that maybe with BA2 there might be a drop off in efficacy, but that's not borne out yet. Guidelines which Jenny pointed out earlier. So essentially, if someone's unvaccinated or partially vaccinated but has no risk factors, or someone's fully vaccinated and is immunocompetent, there is no role for any of these therapeutic interventions. All the studies have been done, and the benefit is really in the people who are at risk of progression. If you're pregnant and unvaccinated or partially unvaccinated and within 7 days of onset of symptoms, then you should be eligible for sotrovimab. It's really only recommended in the 2nd or 3rd trimester. But if you do have a person in the 1st trimester that you think is eligible as multiple risk factors, then feel free to contact either Salin or Nalin ID and the obstetric registrar based on where the postcode of the patient, and discuss it with them. If the patient, for non-pregnant adults, if the patient is unvaccinated or partially vaccinated and within 5 days of symptom onset, there are no contraindications for the protease inhibitor combination Paxlovid, then that would be our first choice. If they are immunosuppressed or they are unvaccinated or partially vaccinated, but they have contraindications to Paxlovid, then you would use sotrovimab. And if you can't use either of them for various reasons, then molnupiravir would be the drug of choice. So in effect, in summary, we have a wide range of therapeutic agents available to us at the moment. So at least 3 different agents. Omicron we know is less virulent, but yet the large burden of disease because of its increased transmissibility is what's led to a large number of cases in the community and hospitalization and a relative shortage of therapeutic agents. Oral antiviral agents, the main limitations are drug interactions, some limitations of its use in pregnancy, and if there is renal or liver dysfunction. Infusions, the main limitations are administration challenges, but we currently have a system whereby this seems to be working well. You refer patients in, they get triaged to the various infusion centers, and that seems to be happening in a timely manner. We don't quite know yet what the long-term efficacy of these drugs is, and this is something I guess we'll have to watch this space. Jenny had covered the web page, which we'll keep updating as things change. So at the moment, it hasn't yet been updated to include the oral antivirals, but that should hopefully happen by sometime next week. One of the changes we've made is from the previous referral form is the vaccination recommendation. So essentially, we point you to the ATAGI guidelines. This is just really so that it's future-proofed. And as the vaccination recommendations change, then you have something to refer to, and we don't have to really change it on the web page. Essentially, the current guidelines is if you are more than 3 months from your 2nd dose, then you would be eligible for the medications. So what do you do when you get your patient either through telehealth or you consult a patient in your rooms? Confirm the diagnosis. One of the things we have changed with the oral antivirals is taking away the requirement to do a PCR, only because we recognize that 5 days, which usually will probably be 2 or 3 days, because by the time they come to you, is probably not going to give enough time for us to be able to do a PCR. So if there's the confirmation would be either through a PCR or a RAT test would be acceptable if they are symptomatic. We would still recommend trying to encourage them to get a PCR, but that's not mandatory for the treatment. For an infusion, it would still be better if we can still, because we have that 7-day window, still to try and see if they can get either a PCR or a rapid PCR. And again, it's not mandatory, but it would be particularly because these patients are coming into a red zone where they'll be with other patients, even though we know that the patients are in masks, it's adequately ventilated and so on. It's important to ensure that you assess the patient adequately for appropriateness of treatment and the choice of medication. The referral form that we've put, that will be up and running from next week onwards, will kind of guide you as you go through the form to either the oral medications or the IV infusion. And it'll help. It's quite self-explanatory, and you should be able to refer the patient without any difficulty. It's important that you explain the patient the benefits of treatment and the reason for referral. We've had patients who've actually turned up at the infusion center not really knowing why they're there. So it would be really, really beneficial for you to explain to the patients what this is all about. We've also got patient information sheets for both the infusions as well as for the oral antivirals, which you could provide to the patient. It is important to ensure pregnancy is ruled out where it's appropriate, and the appropriate counseling is performed, as in if you have to give Monopyravir, making sure that for males know that they have to practice contraception for 3 months, and then contraception during the administration of the drug, and so on. Drug interactions, it's important to have an up-to-date and accurate medication list. Explore the drug interactions using the tool, and we've tried to make the chart on the guideline page as informative as possible, so that you don't have to go searching for various drugs. There might still be drugs that are not on that, but most of the common drugs should be on that. And I guess the other most important thing is, please ensure that we have the correct details, both of the patient with the contact number, as well as the postcode. We've had situations where patients have actually from a certain area, but are actually visiting another area, and then because our infusion, the algorithm actually sends them to the postcode that you enter. So if a patient's in Ceduna, happens to be in Port Augusta, please put the current postcode so that we can actually direct the patient to the right infusion center. And similarly, please put accurate referrer details, both emails and phone numbers, so that if there are any clarifications that need to be made, it's easy for the Datus pharmacist to contact you for clarification, especially with these drugs and the need to make sure that the drug lists are accurate and so on. But probably the most important thing is making sure still that all our patients are vaccinated, they get their booster doses in a timely manner, and as the vaccination advice changes, to make sure that all our patients are up to date with their vaccinations. Thank you.
Thank you, Ranji. That was an incredibly informative presentation. And I think you've covered so much around what people are really interested in to understand around that, the immunology as well. So that was really fabulous. Thank you. I will ask Naomi or Katie if you had anything else specific you wanted to add on to Ranji's presentation, or comments that you wanted to make that have come through, that emerged through the question and answer chat.
Thanks for that, Emily and Ranji. I think most of it's actually been covered by Jenny and by Ranji, thankfully, so I don't have to say too much. But what I will say is, over hopefully the next couple of days, the website where you do those referrals will change significantly. As we add in information about the oral medications, we'll upload the new guidelines on the SA Health template, so they should be up there in the next few days, as well as a lot of that information that Jenny went through about the risk factors, about the immunosuppression criteria, and each of the individual drug monographs. It will also have links there to patient information to help you talk through, or even email the information to patients, so they actually have that, and you can talk to them about it, and they can make their minds up about either the infusion or the oral medications. At the moment, the process for getting the oral medications will very much still be through that online referral form. As we move forward with them going on the PBS, that will obviously change, but at the moment the medications are coming through the NMS, so they're lobbying at the hospital, the SA Health hospital sites. They will be available regionally, but it's just one of those things that for now they will be dispensed by the hospital pharmacies, which means that the patients will get good education, will get patient information leaflets, which we're creating, SA Health ones as well. So hopefully that should all be available, fingers crossed, early next week. Naomi might know more about when it will actually be available, but we're hoping it'll be early next week.
Thank you.
Thanks, Emily. I won't say too much, just quickly. Yeah, be probably middle of next week once we get the IT sorted and uploaded. And just to flag, and I know Deb's on the conference as well, that there's been about 1,328 patients so far referred through, so that's fantastic. But I think, as a number of speakers have said, really trying to now focus on getting those really high risk groups a bit more focused on. So looking at disability, your aged care patients, and also looking at our rural and remote NATSIC group to keep remembering to how we can channel them through the pathway as well as many as we can that'll be eligible. And I know aged care is a big topic. We're hopefully talking to the aged care groups next week as well to help them work through the supply arrangements that the Commonwealth has set up, with a meeting with them tomorrow to find out a little bit more about that as well. So I'll leave it there.
Fabulous, thank you. And I think it's been an incredibly informative webinar. You can see that everyone around this screen, we've got so many helpful people posting in the chat as well, that we're really just keen to educate as much as possible and provide support and reassurance for our community GPs, our primary health practitioners, pharmacists, allied health practitioners who have joined us tonight. And really, this is what's going to get us through COVID over these next few months, is having a really joined up, coordinated approach. So if we can understand how to refer in, and we'll put out information next week through both the PHN and also by the GP liaison email, it'll make it so much easier for us to know how we can manage and care for our patients. And I think we picked up on a few things tonight. There's lots of questions coming through around, you know, what do I do in these specific situations? How do I refer my patient into this specific face-to-face level of care? I have posted into the chat, but also into the Q&A, the most up-to-date version of the slide set that was the statewide community COVID-19 Omicron response to primary care, which actually steps through a number of these pathways and referral processes. It doesn't have the mobile numbers in there for the COVID care centres because they've only just been recently released, and we didn't want to overwhelm the wonderful medical leads at both those sites, noting that both Jackie and Eleanor have posted throughout as well, which has been fabulous, and really keen to make sure as fabulous GPs running these sites, we want to make sure that there's good uptake and also good access to care and understanding of the pathways. So we'll continue to put out more information, and if both are in agreement, we can certainly send out the specific details of those care centres. And the Salem site now has their website up live as well, so we might post that into the Q&A box as well, just to promote that further, and we'll send it out in the GP update. So that brings us to the end of tonight's webinar. A really, really big thank you to all of our panellists who've given up their time and also put together some really fabulous slides as well. Thank you so much to Associate Professor Tom Dodd, always very informative from Tom around where we're up to, and well done on the 3 million tests. We know that TTIQ is what's got us through to this, so the testing right at the front is so important. A big thank you to Jenny Gould, does a fabulous job leading the GP assessment team. Ranji, Katie, Naomi, all the support that you're providing in this space, particularly around this rapid transition to oral therapies as well. Mel in the chat box doing a fabulous job as well as the medical lead of our community response program. And finally, a big thank you to Adelaide PHN for continued support in this space, and a number of partnerships that have been really strengthened, particularly over the last few months. And we're trying to send out some really joined up communication in this space, promoting the face-to-face visits that we can, that GPs can access for your patients who are COVID positive, noting the GP respiratory clinics are there, the ordering processes in for PPE. We've also put information out as well around health pathways. So please, please, please take advantage of the great resources that Adelaide PHN have put together, and also the support that Country SA PHN have provided out to the regions as well. So thank you. Crystal, is there anything you would like to add? Final summary messages from the PHN. Thank you.
No, nothing specifically for me, Emily, just that we now have commissioned our with Wellbeing SA our in-home COVID positive care for regular care. So it's for patients who are COVID positive, currently at the home, but need regular care such as wound dressing, suture removal, diabetes care, and that can be done through the MRU referral process, and the templates are up on our website, and further information can be available through your practice facilitator.
Excellent. Thank you, Crystal. And I've posted it into the Q&A box as well, that referral link. But yes, please check out the PHN resource pages online. Fabulous information there around that new service, around that face-to-face care that can be provided to your patients who are COVID positive through that Commonwealth partnership with the PHN and Wellbeing SA. So big thank you again to everyone. We look forward to our next webinar where we'll bring together more interesting topics. And then we've got our RACGP education series as well, just for that really in-depth technical information that we